Okay, so we are going live. Gaurav sir, you can start.
Right. So,
So,
have you started?
good morning, Gaurav, and
Good morning, sir.
welcome,
Hi.
Thomas.
Good morning, Maulin.
I'm sorry for joining a little late. Yeah, Gaurav, you can proceed, please.
Yeah. So, good morning, everyone. So, today in our journal club of 2024, we'll be starting with three papers. And today we have two experts, very well-renowned senior pediatric orthopedic surgeons, Dr. Maulin sir from Ahmedabad and Dr. Thomas from CMC Vellore. So we have three papers. So we'll start right away with the first paper. Uh, I'll be sharing my screen to start the paper. Joyance, you have to enable this screen sharing.
Yes. I think I've done. I think you can share.
Right. So,
There'll be a share screen button on your.
yeah, I tried that, but this is
Yeah, so
saying,
Gaurav, what's happening?
sir, I am using this
You are
Mac.
mute, probably, Gaurav.
Okay. Am I audible, sir? Hello?
Yes,
Yeah,
yes, it's audible.
Joyance, can you hear Gaurav?
So when
Yes,
Yeah.
sir. I can hear.
I can also hear.
so so when I'm trying to open this, this is saying to allow access and
You see,
uh,
check it now, Gaurav. Can you share? I made multiple participant can share the screen.
yes, sir. I'm trying to do that. Somehow I'm not able to.
पता नहीं वो
So I think let us start with Dr. Joyance's this thing. I'm not able to share this screen. Let me find it out why. Joyance?
Yes, sir. I'll start then. I think
Yeah,
by then, I
please.
think this should get sorted out. Okay. I hope my screen is visible.
Yeah.
Okay. Good morning, everybody. Today, the first journal club of this year, we'll start with this new paper. It's a multicentric study from China. It will be published in this month's Journal of Pediatric Orthopedics. They have studied the duration of hardware retention after radiological union of surgically treated femoral neck fractures in children, and they wanted to study if there is any correlation with the aggravation or occurrence of avascular necrosis of the head or neck after the removal. So their hypothesis was a longer retention of the hardware after the fracture radiological union in surgically treated pediatric femoral neck fracture. It reduces the risk of aggravation or occurrence of avian of the head or neck. So they did a retrospective study of the cases they operated between March 2010 and June 2020. And they included unilateral cases of neck femur fractures without any additional injury or metabolic diseases, and children less than 17 years. And they included only type 2 or type 3 Delbecq fractures. And they included all the children, who had complete clinical radiological data in the postoperative period. And also they included only those children who had a hardware retention of more than 6 months. So a total of 71 children were included, out of which 45 hips were transcervical fractures and 26 hips were cervicotrochanteric fractures. They classified the initial displacement according to the classification by Wong et al., which they published in 2022 in Medicina. So 8 of these fractures were type 1, which is incomplete fractures without any translation or angulation, which is less than 30 degrees. 45 were complete fractures with any angulation and translation less than 50, and 18 were complete with translation greater than 50 degrees, 50%. So out of the 71, 28 underwent close reduction and internal fixation without joint decompression, and 43 underwent open reduction with joint decompression. 56 of them had either stainless steel or titanium CC screws, cancellous screws, and 15 of them were fixed with plate and screws. They also quantified the quality of reduction according to Song et al., which he published in JBGS 2010. So in this, 35 were anatomical classification, anatomical reduction. That means there was no angulation or interfragmentary translation. 34 were acceptable reductions. That means there was an angulation less than 30 degrees or a interfragmentary translation less than 2 mm. And 2 of these children had unacceptable reduction. That means they had a interfragmentary translation of greater than 2 mm. And they quantified the presence of avian based on Radcliffe classification, in which type 1 is avascular necrosis of the head and neck of the femur, type 2 is avian only of the head, and type 3 is avian of the neck. And these are the results. The average age was 9.8 years. The range was 2 to 16. And the follow-up time was 32.5 months. And the range was 12 to 107 months. The average time to achieve radiological union was 3.6 to 1.5 months, plus minus. And in their case series, they did not find any cases of refracture post-implant removal. So in this table, they have according to they have graded the avian according to the demographics. So the gender or the laterality or the type of fracture, there is no significance in the presence of avian. Also, the initial displacement, according to Wong et al., whether it's an incomplete fracture at type 1 or type 2, whether there's a complete fracture with angulation less than 30 degrees, or type 3 with angulation greater than that, they could not find any significance in the occurrence of or aggravation of avian in any of these fracture types. It was independent of the initial fracture displacement. Also, the time from trauma to reduction, also they could not find any significant correlation. A lot of children in their case series came late up to, there were 5.6 days or even greater than that. They were operated even greater than that, but they could not find any significant correlation between the delay in surgery and aggravation or occurrence of avian. Also, children with close reduction or open reduction, there was either groups had similar occurrence of avian. There was no significant correlation. And even the quality of reduction, which Song et al. Had classified, whether it was anatomical reduction or an acceptable or unacceptable, they could not find a correlation. And 26 of these children, they had radiological features of avian before the implant removal. So only positive correlation in this study was the duration of implant retention. So they noted that whenever the hardware was retained more than 7 months, so they had a lesser chance of avian or aggravation of the avian, which is if it's already there. So it had a p-value of 0.003. So they hypothesized that the mechanical damage of the surrounding interosseous blood system induced by screw threads during removal, it can contribute to the increasing risk of occurrence or aggravation of the avian of the neck. So they have claimed this is a unique study because all the other studies, they have not studied the occurrence of avian with implant retention. So previous studies by Wong et al. And Kulka they have noted that stress shielding caused by the implants is caused by these implants in the femoral neck, and the removal of this internal fixation is associated with a greater mechanical stress on the bone structure. And so this can lead to avascular necrosis once these implants are removed. And also, Patman, in his study published in 2013, they have studied that increased duration of hardware retention can promote both trabecular bone remodeling and vessel regeneration. And these can in turn increase the resistance to both mechanical insults during hardware removal and the increased mechanical stresses after the implant removal. So this is probably a way in which delayed implant removal can prevent avian of the head and neck. This was another study where they studied the screw sizes, and so Wang et al. They studied 153 cases of pediatric femoral neck fractures, and they studied that screws of larger size or screws which were closer to the piriformis fossa increase the risk of avian. And also, children treated with 2 cannulated screws had a lesser degree of avascular necrosis than children treated with 3 screws. So the study has quite a few limitations. One is that it's a retrospective study, multicentric study. So multiple surgeons were involved. They haven't elaborated the reduction maneuvers or how many attempts they made. The avascular necrosis of the head and neck, they have quantified with the Ratliff classification, which is a X-ray based classification. They have not quantified with the MRI. And also the clinical or the functional limitation to the child, it's not mentioned. They have not used any patient-based scores, and they have not studied how has it progressed, or did these children require surgical intervention to treat the avian of the head and neck. And they have not studied the relation with the age, whether the avian after implant removal, is there a correlation with the age? Does it occur in adolescents more, or is it in younger children? The takeaway message, I think, would be it is wiser to delay the implant removal after the radiological union rather than deal with avascular necrosis of the neck or head later. Thank you.
So thank you, Dr. Joyance. If there are any questions, you can ask in the chat box. And I have one question from our experts, that what is their experience of having avian at the time or after removal of implant? So, sir, Maulin, sir. Yeah. Yes.
The first, can you hear me, Gaurav?
Yes, sir, very well.
So first thing is whether this paper is strong enough for us to believe this hypothesis. And I see a lot of fallacies here. I would like to know from Thomas, how do you rate this paper, first of all?
Yeah, like Maulin was saying, one thing is it sounds very theoretically very sound. The hypothesis is good. You normally think when you take off the screw, regeneration and blood supply can go in. All that is fine. But my problems with this paper is one, it's retrospective. Second, it's multi-center, different surgeons. Third, there is no objectivity, meaning that, see, in today's world, if you say X-rays, I do avian on X-rays, that itself is a no-no in my view. And then he talks about 7 months. See, there are a lot of discrepancies. See, normally you will get more avian as you go proximal. In his own series, if you look at that table, he has more avian in the type 3 rather than the type 2, which is again out of not in keeping with the, or he says that 40 and 15% and 22% type 2 avian, right? And how did he come up with the 7 months? Suddenly out of the blue, the 7 months is like a Bible truth, you know. Somebody who comes up with a magic figure like 7 months, you should always be wary of. Whether it's
Yes.
9 months, 1 year, you can't say 7 months. If I take it out, there'll be no avian. So for me, there are a lot of holes in this paper, and I'm sure if an Indian had sent it, it wouldn't have been accepted.
So I agree, Thomas, with you. And so, Joyance, first of all, whenever you present the results table, you know, you must point out one by one point that where you found the problem. Can you hear me, Joyance?
Yes, sir.
Yeah. And a fellow's job is to read between the lines, mainly in the results section. And you have to try and find out whether this study is robust or not. I'll tell you what I found. The first thing is the 7 months time, as Thomas has mentioned. So they must have done a retrospective analysis, an implant removal, 6 months, 7 months, 3 months, you know, and then they would have found where is if we draw a cutoff line at 6 months, what's the difference between no AVN, and same, that's how they come. The only thing is, many a times radiologically, we see AVN after 8 months or 9 months of index injury, sometimes as late as 1 year. So that's a confounding factor, that even though you have retained the implant in those patients, they would develop AVN later on. So 7 months is not the time where all the AVNs would appear on the X-ray. So that's one of the fallacy. And as Thomas very well mentioned, we know that completely displaced fractures have a higher rate of AVN, which has been proven in many series. While in this series, they say the placement and displacement of fracture has no correlation. So that's again a problem. The theory which they have proposed, that while removal of implant, you induce this vascular insult. Now, there is no basis of proof. They should have done some vascular studies before and after implant removal, whether it causes any change in the circulation. Now, there are ways to do it. You do the MRIs with vascularity check, which is not done. So, I mean, the inferences which are very, I agree with Thomas that there are a lot of issues with this paper, and we see some papers are getting selected for the journals, which we respect a lot, but there are a lot of fallacies, you know. And many times we do not remove the implants unless it is absolutely required. The implants removal if at all required, we do not do it before 9 months or a year. Now, this paper with this fellows, I will not change my practice, you know. And there's a lesson for all the fellows. Not all published papers are like the rule, you know, that we must read it. And from tomorrow, I will not start removing implants of neck femur at 7 months. In fact, I don't remove implants because that. So, Thomas, do you remove neck femur implants?
Never.
Every time?
Even a skiffy screw, I never remove. I don't
Exactly.
remove.
So, there are very rare complications of stress fractures at the tip of the screw. But if we see the rate of stress fracture or transverse subtrochanteric fracture is very less. So the practice is do not remove the implants unless there is a EVN or control lysis or implant is going up. So this paper, I would not rate a great paper, okay? And I would not change my practice. Thomas, what's your take?
I think you absolutely correct. See, I have done a lot of studies on AVN. One of my earlier publications was an AVN in Skiffy in America when I did in DuPont, and I did. So in that itself, I've actually written that you cannot detect AVN with X-rays before 6 months. And if you detect, it can be wrong, okay? And it takes at least 1 year or 2, like Maulin said, for AVN to be manifest on X-rays. So that is the first punch into this paper. The second one, into today's world of evidence-driven medicine, if you don't have, like Maulin said, MRI or magnetic resonance, perfusion imaging, or bone scan, or some objectivity, this paper will not be accepted. It's not acceptable in today's time for detecting AVN. So, and like Maulin said, no one is going to remove this because on paper level 3 evidence, which is not even, like he said, a practice-changing paper with so many holes, one being retrospective, one being multi-center, different surgeons. And see, statistics you can use to prove your point and your theory, but in practice, or it is not. You know, if you've done many papers, you'll know that you can make a idea sound good with statistics. So to me, this paper, like Maulin said, is not going to change my practice.
That's right. So let's go move on to the other paper.
Yes.
Only message to all the fellows is not all published data is acceptable. And here we like try to teach you which are the points which are against the quality of paper. Yeah, Gaurav,
So
you can proceed.
Yeah, so I hope my screen is visible and I'm audible.
Yes, sir.
Yes.
So yeah, so my paper is titled as Physeal Migration During Knee Guided Growth with Tension Band Plates and the Influence of Implant Position. So this paper has been published in JPO in February 24, and it is published from the Department of Orthopedic Surgery and Traumatology, Madrid, Spain. It was a very exhaustive, very long paper with a lot of parameters. So I tried to simplify it. So we know that guided growth is based on the biomechanical principle of tension band, which is created at the periphery of the physis by using a plate and 2 screws around the growth plate. And continued growth of the remaining physis leads to divergence of the screws. Now, in some cases, the implant movement from the epiphysis towards the metaphysis results in migration of the epiphyseal screw into the physis, as you can see in the lower part of this figure. So this implant is moving towards the metaphysis and this epiphyseal screw is moving towards the growth plate. So this is known as physeal migration. The aim of this study was to determine the positioning factors of tension band plates that influence the risk of physeal migration and to study the clinical implications of physeal migration. It's a retrospective study of 491 patients who underwent temporary hemi or epiphysiodesis around the knee between 2007 to 2019 with two different 8-plate systems, Orthofix and Orthopediatrics. Out of these, they found that 29 patients, that is around 6%, had plate migration. And in these 29 patients, 45 out of 72 tension band plates were migrated during the follow-up, which was kept as minimum 3 years or till skeletal maturity. Now, the plates that had migrated were the cases, and they were matched with other plates inserted in the same patient at a similar location with no migration, and these plates acted as controls. So, cases with no control plate in similar location and patients with inadequate radiographs were excluded. Thus, 24 cases were matched with 24 controls. Now, these all were the radiographic parameters which they measured. Is my arrow visible on the screen? Is this cursor
Yes.
visible? Okay.
Yeah.
So first was epiphyseal screw base and physeal height. So this distance from the growth plate. Then there was epiphyseal screw tip and physeal distance from the growth plate. Then inter screw angle. Then epiphyseal screw and physeal angle. Metaphyseal screw, sorry, this was the epiphyseal screw and physeal angle. Then metaphyseal screw, metaphyseal screw and the physeal angle. Then plate physeal angle, epiphyseal screw and plate angle. So this is the epiphyseal screw and the angle with the plate. Then metaphyseal screw and the plate angle, and then the ratio of epiphyseal screw length with the physis. They defined all these parameters and they defined when they will call it abnormally placed screw. So they measured these parameters on each 8-plate in all the cases and the control groups where they have migrated and where they haven't migrated. And they classified migration as touch when the screw came into the contact with physis without penetrating it, occupy when the screw penetrated the physis without entering the metaphysis, and traverse when the screw passed into the metaphysis. Also, on the basis of this migration, the status of physis was evaluated as unaltered if no anomalies were identified in the physis, physeal bar when a physeal bridge was identified, and skeletal maturity when the entire physis was closed. So in results, there were 29 cases of physeal migration, and majority of them were idiopathic cases. Apart from that, others are cerebral palsy, hemihypertrophy, achondroplasia, arthrogryposis, Blount's, and benign tumor. The median age at the time of index surgery was 12.2 years. There were 76% males. 33 knees were intervened for leg length discrepancy, 35% for genu varum, and 21% for genu valgum, and 11% for knee flexion deformity. So majority of their cases were for genu varum, in contrast to our practice where majority of cases are genu valgum. In the results, they found that among these 45 migrated plates, majority were from the lateral proximal tibia and followed by medial distal femur and others. So out of these 45 migrated implants, 16 cases touched the physis, 17 occupied, and 12 traversed. So as you can see in these figures, this is immediate post-surgery, and this is in the follow-up, where you can see 3 plates. Out of them, one touched, one occupied, and one traversed the physis. So then when they measured all these parameters, they found statistically significant difference for epiphyseal screw base, physeal distance, epiphyseal screw tip, physeal distance, epiphyseal screw and physeal angle, epiphyseal screw and physeal angle, this angle, and plate physeal angle, this angle. These four parameters had a statistically significant difference. They also came out with this observation that epiphyseal screws at a convergent angle were significantly more likely to undergo migration. To discuss, this is the largest series of implant migration to the physis after knee guided growth. It shows a physeal migration rate of 6%, around 6%, similar to other previous studies. There were no significant differences in screw length between cases and controls, in contrast to our traditional belief that screw length affects pull-out or migration. There were no physeal bar formation. However, authors suggest considering screw removal or modification when physeal migration is detected. And there was no case of broken screws among the migrated hardware. So the ones which migrated didn't broke. They also hypothesized the mechanism of physeal migration. So as you can see in this figure, the growth of the physis happens from epiphysis to metaphysis, and this growth pushes the metaphyseal screw with more force on the tip of the metaphyseal screw. So this metaphyseal screw starts acting as a cantilever beam, and then it starts diverging. Now, as it diverges, it drags the entire plate along with the epiphyseal screw with more force at the base of the epiphyseal screw than the tip, leading to migration of the entire implant towards the metaphysis and the migration of the epiphyseal screw towards the physis. So there is more force at the base of the epiphyseal screw and at the tip of the metaphyseal screw. And this causes this physeal migration of the epiphyseal screw towards the physis. Now, more convergent placement of this screw increases the chances of physeal migration, and reduced anchorage of the epiphyseal screw in osteopenic bones, usually which we see in these cases associated with rickets. So they also promote physeal migration. And this point was also discussed in previous papers. So the limitations of this study are it's a retrospective case control study, and thus the results help in establishing relationships but not the causality. Physis is a 3D and complex structure, and this study has evaluated the phenomena of migration based only on the AP radiographs. There are other limitations also, as initially the number they have selected is 491, where they have selected a lot of hemi cases, but then they have taken only those cases where there was a similar plate at similar location. So they have only chosen the ones with total epiphysodesis. Then they have given a hypothesis, but they have not tested that hypothesis. So in conclusion, physeal migration of tension band plate is not an uncommon phenomenon, although no physeal abnormalities were detected, and placement of the epiphyseal screw with the base or tip close to the physis and convergent to the epiphyseal plate should be avoided, as it is associated with a higher risk of physeal migration. Now, my takeaways are it made me understand better maybe the most probable cause of physeal migration of implant and the epiphyseal screw. And usually also we have learned that we should not put convergent screws, but I'll be more vigilant about it, and I will be more vigilant about placement of my epiphyseal screw uh, in relation to the physis. Also, I would like to analyze my cases of both where I have achieved correction and the ones where I haven't, to with by measuring all these radiological parameters to find out maybe the cause for the failures, maybe the implant position. And also I would like to analyze my cases of pets where I would like to see the change in position of single screw across the physis over the follow-up. Thank you, and this is open for discussion.
Yeah, so I would invite Tom.
Yeah. So I think it's an interesting study. I've never actually looked at migration of these screws, but some drawbacks, like Gaurav mentioned, is one is it's retrospective. Two, it will make intuitive sense to actually know that when this migration will happen in osteopenic or bones which are sick physes, they say, no, so those with rickets or those with epiphyseal dysplasia, those whose bone health is not so great. So my problem is, and the age, of course, the age of the patient. So they've not stratified the paper to make it more sound. First, by doing a baseline DEXA or finding out the bone mineral density, to dividing it among, they already, like Gaurav said, they have a selection bias. They only had controls and cases where they chose patients which have equal on both. So already before doing the study itself, they have a selection bias. And when you do studies like that, it's an interesting concept, all these radiological measurements. And one thing about radiological studies, no, you have to get the X-rays perfect, standardized. Then you have to measure these angles. 3 fellows have to measure, get the intraclass coefficient. So all those things, I don't know if it's been done in this paper. I didn't really look at it very closely, but and this theory about this convergent screw pulling out more is fascinating. I mean, I have not looked at it like that, and then I have not had so many screw migration. I've not really looked at it. So it's an interesting thing that I should probably look at all my patients with this kind of screw migration.
So one thing I would like to add is they, yeah, as Dr. Thomas said, they have not done a pre-surgery DEXA, but they have mentioned that in their cases there was no osteopenia or bone weakness of bone, although they have not objectified or
that is a thing.
done a test. Yeah, and second thing is, so this was the point, right?
Age also.
Hello.
Yeah. Can you hear me now, Gaurav?
Yes, sir. Now I can.
Yeah. So a few points which should have been mentioned. No, we know that implant pull out or migration has something to do with the magnitude of deformity. If you are dealing with a 35 degrees of genu valgum and you have placed the implant straight, after certain degrees of divergence, the plate will back out or the epiphyseal screw will start moving. So one thing which is missing is the degree of deformity and what is the relation with this. So that has not been mentioned. Metabolic profile of a child, like we treat a lot of, I have seen this happening in hypophosphatemic rickets, which is not very well controlled. And the epiphyseal dysplasia or the younger children where the hold of screw in the epiphyseal ossification center is not good, then we see this phenomenon more frequently. The average age where the authors have mentioned is 12.2 years, so they have done this procedure mostly in the near skeletally mature patients. The third thing is how in the knee FFD patient this is different. The implants which is placed in sagittal plane and coronal plane, how it is different that they should have mentioned, and whether it makes a real difference. What happens to that physis? Now, radiologically, we see that the screw has traversed or touched or occupied physis, but it has occupied a very small area of physis. So whether this physial touch leads to any growth alteration, you know what I mean? Because it's a slow process. It has happened over many months, but that might not have any physial bar formation leading to aggravation of the deformity, or in other words, whether it had made any difference in your correction, you know. So
Right, sir.
or when you remove the implant, whether it will lead to a permanent physial damage. So those things needs what happens to the long-term outcome of those where the plates have migrated. That if there is no difference, for instance, if your screw has migrated or occupied the physis, the deformity got corrected, and you remove the implant and the deformity remained corrected, that means that that migrated screw did not have any effect. You understand? So
Right,
this point should be covered, and few etiological factors have not been considered. They have applied all these things. When I would feel, and we have experienced that the implant migration or back out has higher association with low mineral density in metabolic bone disease patients with higher degrees of angulation correction, and younger children where the epiphyseal hold is lesser than near skeletal maturity child. So
Yes.
whether this will change my practice, like we have been trying to put the screws either in a parallel or parallel to each other, or a little divergent. We do not try to put it in a convergent fashion, because we know that it's not the compression of the physis which gives the correction. It is the tethering of physis which gives us distraction at this. So I don't know whether this would change my practice, but based on this paper you have studied very in detailed way, what would you suggest? Will it change our current practice of screw placement? We do not put in convergent fashion. We always put either transverse or little divergent.
Right, sir. So I have 2 points to make. One is that this point is very well, which you have made, that they have not taken into account the degree of deformity, which they should also have studied. Second is they have mentioned that this migration has not caused a single case of bar formation or any other physical abnormalities on the basis of clinical outcomes or follow-ups. So, and they have mentioned that this might be due to the slow process of migration, that the growth plate, that there were no clinical negatives of this physeal migration. Now, in my practice, as I've learned from you, that we never put convergent screws, but there were two cases where I thought that the implant which has migrated in my case might be due to a smaller screw. So I tried to put a bigger screw, and then they got corrected. But they have mentioned that the length of the screw does not make much impact in migration or pulling out of the implant, specifically
So,
migration.
so what happens, Gaurav, when you put the first thing is it's a tethering on the physis which induces correction. So the length of screw has nothing to do with the correction speed or correction amount. The only thing is, once your screw reaches to an optimum level of divergence, then the plate would start coming out, because it wants to have more distance between the screw tips. At that point, if you have used smaller screw, then this screw will move out of the cortex and the implant will become prominent. So that's why uh, you should put a screw which, in an internal rotation view, your epiphyseal screw should not go beyond the condylar line, because then if you are projecting posteriorly, it might go into the notch and popliteal vessels are at risk. The same length of screw you can use on the metaphyseal side. So the length of screw is not important as far as the correction is concerned. One other point which Thomas already mentioned, that the reliability of all this angular measurement, now we know that even with the 10 degree of rotation, we see the placement of your guide wire changes significantly. So first we should have the reliability test of all the radiologic parameters which have been indicated. Like it has been studied by a radiologist, by an orthopedic fellow, by a consultant, whether it makes any difference. There's so many measurements which can be easily done on PACS, but its reliability is questionable. So let's take this that we have to be vigilant. We should not put the screws in convergent fashion. That should be the takeaway. And if the screw starts migrating, then it means that it has exhausted their divergence, character. So you have to replace and rechange the position. Fine. Let's
Right,
move
sir.
on to the Thomas. Any point you would like to make?
The other population they've not studied is what we find is in CP and meningomyelocele. That is also a population where we have a decreased bone health and osteopenic bone. So I'm surprised that they didn't study that population also.
So they had 3 cases of CP which were included, but then they have mentioned this line that there was no osteopenia, although they have not justified it by any investigation. And one more strange thing was that, sorry sir, last point, till the time Tashfin is sharing his screen. One more point is strange is that majority of their cases were genu varum. Like we see, I mean, the ratio is quite different. We see majority as valgum.
Yeah.
So genu varum has typically been associated with hypophosphatemic rickets, X-linked, and adolescent idiopathic genu valgums, which we see they are metabolically better. They have genu valgum, So they might have this although they have mentioned that they were not osteopenic, but they should have considered this metabolic profile,
Right, sir.
So it was a good paper, thought-provoking. Yeah, Tashfin, you can share your screen. I mean, make it a white screen. So Dr. Tashfin Rubaiath is our new fellow. He has joined from Bangladesh, Dhaka. He was a senior registrar at Nitor, and he has joined our team now. Yeah, Tashfin, you can make it a.
So am I audible?
You're audible, but your screen should go wide.
Okay. Sir. Is it okay, sir?
Yeah, please proceed.
So my presentation on 12 to 20-year follow-up of Degas acetobuloplasty in patient with developmental dysplasia of hip. Is it as effective as expected? And it was published at Journal of Pediatric Orthopedic 2024 and level of evidence 4. So the aims of the study is the purpose of the study was to evaluate the rate of residual acetabular dysplasia after Degas acetobuloplasty. And the method was it was a retrospective study. Sample size was 35 patients. Average age is 19.2. That's mean it's years. Operator surgeon, single surgeon. Mean age at time of surgery is 35 months, 80 to 65. And the tools they use to measure, that's a lateral central age angle, femoral head extrusion index, and Tonys angle. And outcome was evaluated by radiologically by Severin classification and clinically by modified McKay criteria. So these are the angle, Tonys angle, femoral head extrusion index, and lateral central age angle. And the result, they have patient demographically and outcome where they have shown that according to radiologically and clinically, there is almost 22 patients are excellent. Only 7 was had goes to AVN, and out of 7, the 2 needs to further operation. And this is the latest follow-up radiograph of case 28, where they show the right hip dysplasia of residual dysplasia. And another figure, the latest follow-up of a case demonstrating overgrowth at the right hip. On discussion, they found only 2 studies have reported long-term result of degastroblasty. One of this is the study reported by Elside et al., where the sample was 58 hips, follow-up for 13 to 25 years, and 44 hips had a survival with excellent or good results according to modified Mackay criteria, and 42 hips were severe in grade 1 or 2. In addition, 7 of 58 hips underwent pelvic osteotomies for residual acetabular dysplasia. And another long follow-up of study reported by Wozniak et al. Sample was 67 hips of patients younger than 5 years of age. They showed that survival rates were 100% at 30 years, 73% at 40 years, 64% at 43 years. The ABN rate was 63.2% despite performing shortening in 96% of cases to lower the pressure on the femoral head. And ABN or proximal femoral growth disturbance was the complication, and 23 remains the most common complication of DDS treatment, with varying rates reported in literature from 0 to 73%. And the results in this article were comparable to Salter osteotomy reports with similar follow-up time. However, long-term studies about Salter osteotomy have shown that hip survival becomes vulnerable after the age of 30, especially in the patients with mild hip deformity. There are some limitations as the case number is small. There was no control group with the different types of pelvic osteotomy. Not evaluate another important parameter of hip dysplasia, the anterior center edge angle, which reflects anterior coverage of the femoral head. The modified Mackay criteria for reporting the clinical outcomes of each hip in bilateral cases, as the findings are not truly independent and one hip might affect the other. The take-home message is acetabular is a versatile procedure which is indicated after age of 18 months, allows correction of anterior, lateral, and posterior deficiency by hinging into the triradiate cartilage, and it is the procedure of choice as it provides remarkable correction of the acetabular index. It also increases the acetabular volume and improves the coverage of the femoral head. Thank you.
Yeah, so Tashfin, this was your first attempt at presenting, and I would congratulate. You're nicely presented. But, I want my fellows to judge the paper by their own acumen, and we are not here to just write what the journal has mentioned, So let's hear from Dr. Thomas how he liked or disliked this paper. So Thomas,
Yeah.
what I feel is here they try to kind of compare the Dega with Salter osteotomy, because the Salter's osteotomy has the largest follow-up. Is that right? And what do you think about this paper?
Yeah. So Maulin and me are both from Sick Kids. So we come from the home of Salter, and we were probably the last few fellows who actually saw Salter alive. So we have a bias towards Salter. But the paper is quite good, to go do a 10-year follow-up itself is remarkable. If you do hips here in India, you realize getting follow-up for even 5 years, 4 years is very difficult. So in that way, it's a remarkable paper. And they've done a medium-term publication also at 17 years or before, when they had lesser patients. One thing is, I have not studied my Salter, but all these indices, the acetabular index, center edge angle, head extrusion, will definitely improve whether you do Salter or Dega. But doing a case control study in this is very, very different. To get a higher grade 1, grade 2 recommendation in hips is very, very difficult to have either a case control or randomized control. So all these are retrospective series where it in itself is a inherent bias, and following up a hip for 10, 15 years in itself is a great thing, I think. So in that manner, there are very few papers which talk about Dega and Salter. So I think it's a good paper. I think it also forces us to look at our own results in Dega and Salter. It probably is something that is good, I think.
Yeah, so I agree with you, Thomas. Now, the major difference, as we all know, the fellow, this is the redirectional and reshaping osteotomy. The issue with the Salter osteotomy, as we know, that this might, when an overcorrection, this might lead to impingement later on, or in some of the patients, it might give a posterior instability. And in Dega, again, this overcoverage can lead to impingement. So it's a volume reducing osteotomy. Now, AVN is not dependent on what sort of acetabular procedure you do. Now, here, authors are discussing a lot of things about AVN. AVN might also have to deal with the type of dislocation, how much higher the dislocation was. It also depends on what surgeon, with what grade of training and experience they have done this procedure. So AVN is not a measure of success or failure of an acetabular procedure. What really matters is what happens on a longer term with an acetabular procedure, how long the hip lasts. And there are a lot of confounding factors, like if the AVN happens or if the AVN does not happen, the outcome of that hip, irrespective of the acetabular procedure, would be different. So probably this paper shows that at a medium-term follow-up, you do Salter osteotomy or you do Dega, the outcomes are comparable. We do not know what will happen at a longer term, because we need to have a longer term follow-up of this. Now, the Salter's paper is 45 years of follow-up, and they have found that about 55% hips, they remain normal. Rest of them need a total hip replacement. So in longer term, this happens. Technically, those people who have not been exposed to Salter osteotomy, they find it a bit challenging than doing a Dega. But the Dega also, as a set of complications it can have if you go a bit haywire. So the take home is it's a good paper, but we need to know it's kind of trying to compare Salter and Dega, and one can, at a medium term, the outcome of both this procedure are the same. The outcome of hip does not solely rely on acetabular procedure. There should be also, there are other factors, and like the dislocation type and the experience of surgeon as well. So Thomas, would you change your practice, or have you any preference?
Like you said very correctly, that it depends on where you're trained, your preference for whether you want to do Salter or Dega, and the thing about AVN is very true.
Yeah. Now you have seen both the worlds, Thomas.
Yeah.
So
I do both.
How do you decide that you would consider a Salter in one patient over Dega and Dega in other over Salter?
Yeah. So, like you said, Salter is not a redirection, hinging on the pubic symphysis. No? So I find in younger children, less than 3, I always tend to favor the Salter, because in Dega, it's not yet bony, and to bring the shelf down, I find it difficult. So for me, I do a Dega only after 2.5, 3 years of age. And if I have to do a acetabular procedure before 2.5 to 3, I always go do a Salter. That is one.
Yeah.
And then, as you said, I do a lot of arthrogram, intra-op assessment of my reduction. It all depends on your learning curve. In DDH, there's a long learning curve. The number of hits you do matters, and how your results and your avian, like you rightly mentioned, also makes a difference. But that one thing he said about after 30 years, that Salters become vulnerable. That was not mentioned in Wedge's paper, which you mentioned at a 45-year-old follow-up. So I'm wondering where that thing came about, that he mentioned that after 30 years, a Salter osteotomy actually crumbles or something he mentioned.
No, so it's a 45-year follow-up, and there's no mention at intermediate term 30 years. There was a paper from Salter, which is little lesser follow-up. And then this the Simon Thomas took from Great Ormond Street, and with John Wedge. Anyways, but again, the amount of angular correction, if it is more than 20 degrees, very steep acetabulum, still you do Salter in younger children, or you do Dega for a larger correction?
Yeah, so I actually look at the deficiency per op, look at the head, and see whether it's more of the anterior or more of the lateral that I need, and then decide. That also goes into my decision making. If it's more anterior, I prefer the Salter. If it's more lateral and more, I prefer the Dega. And as I said, the age also matters for me on how to hinge the Dega down. Makes a big difference. There are some MCH students which because today is a holiday, most of them I forced. I'm sure some of them will want to ask you some questions, Maulin. This is the first time they're interacting with you.
Yeah.
So any of you
ask them, don't ask very difficult questions.
No. We just passed, our first batch just passed out this year.
Yeah.
So anybody have any questions, you can ask Maulin. Maulin, a good friend of mine, very, very well read, one of my good buddies. Arul, Meer.
What the Thomas we can also do is we can I'll make you admin of our fellows group temporarily, so you can add your students, and they will get update of weekly academic activities. So and they can join if they have time, you know.
Yeah, the problem is it's on a holiday only week. We have this day to, like, today's a holiday. That's why we could join your thing. We'll always like to join any academic thing, you know, but we can't because of our
but then there are recordings on OrthoTV and on our channel. They can always have a look when they have time.
Okay.
Great. So if they don't have any question, I think it's time to wind up. Thomas, we may do your departmental meeting. We can do some case discussions.
Because
maybe on brachial plexus.
CP thing with Abe joining in from Sydney. We have a very weekly cerebral palsy session with 3D VG analysis, a very in-depth thing for our fellows and MCH students. So that may benefit.
So I'll be happy to participate when you think I'll be of help. So thank you everyone, and I congratulate all the fellows, especially Tashfin for good beginning. Gaurav, as usual, very elaborative and well-read paper. Thomas and Joyance is also a great skill of presentation and reading between the lines. But you are not here just a presenter, okay? You are we have to dig out the problems, and that's how you learn how to create good papers. Yeah.
Good, Tashfin. Good start.
Yeah. Thanks, Thomas, for your time. I'll take your leave. Thank you. Take care.
Thank you. Thank you, sir.